to your patient. So this is a rubric. If you aren't familiar with it, you probably should. You have a classical in a week. So I'm going to go over interventions, frequency, duration, goals, and outcomes. And then it's supposed to be in collaboration with the patient. And then we'll also go over like impairments, functional limitations, and diagnosis and prognosis. So when doing a plan of care, we have to consider current condition, comorbidities, age, health status, resources, living environment, and potential discharge. So plan of care is respectful of and responsive to the individual and their values, and they can also change depending on activity. So the frequency, like the difference between inpatient and outpatient is usually 1 to 3 days per week, and inpatient are typically seen 1 to 2 times per day while you're in the hospital. And the duration is pretty much the same with outpatient and inpatient, but outpatient, it kind of varies on patient presentation, and then inpatient, the duration of therapy is usually short term. And then plan interventions, again, it's kind of the same with inpatient and outpatient. They include type, dosage, equipment, area, target tissue, and side, position and timing, and then functional training, so you're gonna go over gait or transfer training, and then you record the same thing, kind of patient activity, performance, conditions, weight bearing, assisted device, etc. And then assistance provided. And then ultimately for inpatient, you wanna focus on the daily tasks needed to return home safely. And then again, goals and expected outcomes, outpatient versus inpatient. Outpatient is improve and enhance quality of life and returning to ADLs, and then inpatient is minimize functional decline and determine safe discharge. So you kind of just want to prevent further complications, and then they're both using SMART outline and then address the ABCD.
Okay. So we have a case example for you guys. So we're gonna go through the case, but afterwards we'd like you guys to participate and kind of come up with what you think you would put for the frequency, duration, plan interventions, goals, and expected outcomes. And then we'll give you our input and what we chose. I think it's important for you guys to know that it's not like cookie cutter, right? We're like addressing the patient, and our perspective of the patient can be different from like Krista's perspective or like Priest's perspective. It can vary like slightly. So just know that. So the patient, 65-year-old admitted with a right ischemic stroke complicated with a UTI. They've not been out of bed. Our order is to eval and treat, and their weight bear as tolerated. Activity order is to get the patient out of bed to a chair. The medications, gabapentin, Luminox, ciprofloxacin, metformin, past medical history, type 2 diabetes, they have depression. So for significant subjective findings, the patient does not know the date or where they are, no history of falls, lives alone with family living nearby, 1-story home with 1 step to enter, they have a walk-in shower with no grab bars, prior level of function, independent with gait and ADLs, they enjoy short walks and game nights with friends. Their goal is just to go home. Significant exam findings, MMT show left upper extremity and lower extremity 3 out of 5, right upper extremity, lower extremity is 5 out of 5, poor seated balance, modest assist with bed mobility, max assist sit to stand, max assist with squat pivot transfer. So what do you guys think for this patient would be the frequency? How many times a day should we see this patient, and for like how long in the hospital? These are the recommendations that we kind of went through with Parisa stated. So for a hospital, seeing this patient, and they're like, what do you guys think? Anyone, just shout it.
I think 1 to 2 times is great.
Yeah, I think so too. Especially since they have like they just had a stroke and they have a UTI, so like I think like 2 times a day would be awesome, right? Especially since they're at like mod assist and max assist. I think that's appropriate too.
Erin, I'm gonna throw something in.
Yeah.
So remember, they have a UTI, they're on an antibiotic. So once that kicks in, then they should start to recall things and be able to help more. So that's a good point to do 1 to 2 times a day. Also, if you have to justify it in your notes. The other thing is remember, this person used to live by themselves and they're a max assist. So we definitely have some time they're gonna be in the hospital to get them back to that independent level of function. So that'll kind of help determine your longevity or the next step, so, okay.
Perfect, thank you. And then what do you guys think for the duration? So the amount of time we're spending with the patient in the room, and then how long we should like think that they're gonna be there in the hospital?
30, 45 minutes.
Yeah, 30, 45 minutes. I think we put 45 to 60 just because of like the amount of time that it takes for us to give like the help. And then how long in the hospital? How to tell them? A week? Yeah, so you always wanna go more towards the like lengthy aspect and of what you think it should be, right? So at this time, like they need a lot of help and their condition's still a little unstable, so definitely a week would be good. Okay, so planned interventions. What do you guys think? I'll keep going back and forth. I don't know what you guys want to look at. So they need to be functional, daily tasks to return home safely.
Mobility.
Yeah. Yeah. So yeah, everything that we kind of did for like the exam, right? So bed mobility, balance.
Some step training, so you have the step.
Yeah, doing step training. Perfect. Okay, and then last thing, goals, expected outcomes, minimize functional decline, and determine safe discharge. So mainly, we're focusing on, for at least it's practical, we don't have to determine safe discharge where they're going to be going, but we should be still minimizing their functional decline. So what goals should we have?
Being independent with their bed mobility and better or less assistance with sit, stand, and walking.
Good. Sweet. So how to verbalize plan of care. We put the PT diagnosis and prognosis first because we think that's a good flow when you guys are doing the practical. State those things first, and then the plan of care just kind of like flows with it. So after our session today, I noticed you need help with moving in the bed and standing because of the weakness you are experiencing after your stroke and stiffness from being on bed rest. PT would be beneficial to improve your strength and balance. Plan of care, I plan to see you 1 to 2 times a day for the next week with the sessions lasting about 45 to 60 minutes. We will work on improving your strength and balance through practicing bed mobility and doing sit-to-stands. Once you leave the hospital, this will help you progress to walking safely and being independent with home tasks. Both will work towards your goal of going home. And I kind of put an asterisk there, right? So we don't have to talk about the discharge plan, but it's really important for us to mention that because they could just be leaving the next day and they might not understand or be on the same page with what's expected. So it's really important for us to say, hey, you're gonna be going to a skilled nursing facility, an inpatient facility, or going home. Where do you guys think that this patient should go? Inpatient, yeah, an IRF. We agree. And and I also want to say too, like it's important for us to say this every time we see them. So even if it's twice a day, because they could be leaving when from the time that we see them, we might not be able to see them next time we expect to see them, right? So it's just important to reiterate and just make sure that if it changes, that we're telling them. And yeah. So we have another case. So this is outpatient.
All right, so for our outpatient, we have a 40-year-old patient complaining of low back pain. The orders from the orthopedic specialist are to eval and treat. The medications are listed as well as past medical history. Significance, subjective findings. The patient has intermittent pain that is deep and achy. That's diffuse low back pain for the last 2 years. The pain recently has gotten worse with new exercise routine. They are stiff in the morning and after sitting for long periods of time. The pain is worse with picking up objects from the floor and twisting to reach for things. The patient's goal is to get rid of the back pain and to start exercising regularly. The significant evaluation findings, we observe an anterior pelvic tilt with excessive lumbar lordosis, back pain that is 2 out of 10 at rest, and 7 out of 10 at its worst. They have a positive Thomas test with bilateral tight hip flexors and quads, weakness in bilateral glute med and glute max, and then stiff and painful L3, L4. So same thing, what would you recommend for frequency for this patient?
2 times a week.
3. Sorry. I would do 3.
Yeah, we said like 2 to 3 times a week. It depends on when the patient can actually come in. So if they can't come in 3 times a week, then you can bump it down to 2 times a week. Duration, so how long do you think the sessions will be? And then how long do you think therapy will last?
Usually 1 hour.
45 to an hour.
Yep, we said 45 to an hour. And then how long would you prescribe therapy for? 8 weeks? Yeah, and I think we ended up saying 4 to 6 weeks. Obviously, that can vary. It's better to be safe and kind of do the longer duration than be shorter. And then planned interventions. What kind of things would you want to work on? Yep. Anything else?
Pain control.
Yeah. Anything else? What's that? Yeah. So we said address the glute weakness as well as the tight hip flexors and pain modulation as well. And then goals and expected outcomes. What do you think? So let's see, their goal was to get rid of the back pain and start exercising routinely.
So get rid of pain.
Yeah.
All right, so this is kind of what we came up with. So PT diagnosis, prognosis. So from our session today, I noticed you were having some general weakness and tight muscles around your hip region that may be related to your back pain. This is impacting your ability to lift objects and go about your regular exercise routine. PT would be beneficial to address your tight muscles, work on building strength around your hips, and then using methods to decrease your back pain. I would like to see you 2 to 3 times a week for the next 4 to 6 weeks, with our sessions lasting about 45 to 60 minutes. We'll plan to work on improving your strength and flexibility through exercises that target your hip region. We'll also work on decreasing your pain through modalities and manual therapy techniques. And as we address these things, I would expect you to be able to return to your regular activities, be able to lift objects from the floor, and work out without pain. And that's it.